Today we are diving deep into a topic that's, well, it's both fascinating and a little uncomfortable. It really sits at the heart of modern medicine. We're talking about the true cost of getting an accurate, fast diagnosis. We're talking about CT scans. And let's start with a basic truth here. CT scans are, they're indispensable, they're incredibly fast, they're accurate, and in a trauma situation, they're absolute lifesavers. We rely on them. But how much do we rely on them? Well, in 2023 alone, the U.S. performed about 93 million CT examinations.
On 62 million patients, that's an industrial scale of medical imaging.
It is. But there's always been this known caveat, right? CT imaging uses ionizing radiation.
And ionizing radiation is a known carcinogen, so the question isn't if there's a risk.
No, the question is how big is that risk, really?
Yeah.
Especially given how much we use them. So our mission for this deep dive is to unpack a brand new, really comprehensive risk model. It projects the lifetime cancer incidence from those 93 million scans in just 1 year. And we wanted to get the bottom line right up front. The number is, well, it's sobering. This study projects that approximately 103,000 future cancers will result from the scans performed in 2023.
Right. And that 103,000 figure, it immediately elevates this from just a clinical concern to a major public health issue. I mean, if you connect this to the bigger picture, let's assume our... Then we're looking at a future where CT-associated cancers could account for a full 5% of all new cancer diagnoses every single year.
5%. Can you put that number in context for us?
Sure. Think about the big cancer risks we're always told to mitigate. Alcohol consumption, for example, accounts for about 5.4% of new cancer diagnoses.
Okay, so right on par.
Right on par. And excess body weight is about 7.6%. So this puts the risk from a necessary medical procedure in the same league as these massive, well-publicized lifestyle risk factors.
And that's what makes it so alarming. I mean, you can choose to quit smoking or change your diet, but avoiding a CT scan when a doctor says it's essential, that's a very different kind of choice.
It's a different calculus entirely.
Okay, so let's unpack this risk profile because that 103,000 number isn't spread out evenly across all those scans.
No, not at all. You have to make a really clear distinction between the per examination risk and the total number of projected cancers.
And where is the per examination risk highest?
Well, purely from a radiobiology standpoint, the risk is much, much higher in children and adolescents.
Because their cells are dividing more rapidly.
Exactly. The tissues are still developing, so the cancer risk goes down pretty dramatically with age and exposure.
Give us a concrete example. Just how sensitive are the youngest patients?
The difference is striking. If you look at girls who are younger than 1 year old, the projected risk was 20 cancers for every 1,000 examinations.
20 per thousand. That sounds incredibly high.
It's an extremely high sensitivity rate. But, and this is the key point, that's not where the bulk of the problem lies in terms of public health numbers.
So if kids are so much more sensitive to the radiation, why don't they account for most of the projected cancers?
It's that sheer volume you mentioned at the start. It's all about utilization. Despite that high per exam risk in kids, the overwhelming majority of scans are done on adults.
So the volume just outweighs the sensitivity.
Completely. Children account for about 9,700 of the projected cases. Adults, on the other hand, account for 93,000 cases.
So that's 91% of the total projected cancer.
91%. The volume of scans in middle-aged and older adults is what drives the overall number.
Can we pinpoint a peak age group within that adult population?
We can. The single group with the highest number of projected cancers are those aged 50 to 59 years old. They're getting scanned frequently for complex issues, and that accumulation really adds up. And we can get even more specific. We can connect these projected cancers to the actual parts of the body being scanned.
Because the dose depends entirely on the body part and the technique being used.
Precisely. And for adults, the biggest contributor by far is the abdomen and pelvis CT.
Which makes sense. Those are incredibly common scans.
They are. They're used for everything from appendicitis to kidney stones. So that category alone accounts for 37,500 projected cancers. That's 37% of the total.
Wow.
After that, chest CT is the next largest, projecting about 21,500 cancers.
And I imagine the picture is totally different for children, right? They're not getting scanned for the same reasons.
Completely different. For kids, the biggest driver of risk is head CT. That accounts for 53% of all the cancers projected in the pediatric group. There's also one other interesting area to point out: full-body CT exams.
The ones you see for trauma screening.
Exactly. They only make up about 5% of all scans. but they project a much higher proportion of cancers, almost 8% of the total.
Because the radiation dose is spread across so many different sensitive tissues.
You've got it. It's just a marker for a very high-dose procedure.
Okay, that breakdown makes sense. So now let's get to the end result. What specific types of cancer are we talking about here? The single most common projected cancer is lung cancer at 22,400 cases.
Mm-hmm.
And, when you hear lung cancer, your mind immediately goes to smoking.
Of course.
To think that 1 year of medical imaging is projected to cause over 22,000 cases of a cancer we almost exclusively associate with lifestyle choices, that really changes the perspective on this.
It does. And following lung cancer, the next on the list are colon cancer, leukemia, and bladder cancer.
What about differences between men and women?
That's a great question, and the data there is very clear. For female patients, while lung cancer is still #1 overall, breast cancer becomes the second most common projected type.
How many cases?
About 5,700. The breast tissue is just very sensitive to radiation, so it's a major area of concern.
And what about for kids? We said head CT was the most common scan type for them?
Right, and the cancers projected in children reflect the sensitivity of the developing tissues, especially their endocrine organs.
So things like the thyroid?
Exactly. Thyroid cancer is #1 with 3,500 projected cases in children. After that, it's lung and breast cancer.
That is really sobering data. So now we have to talk about the elephant in the room. This projection, 103,000 cancers, is 3 to 4 times higher than the last big analysis.
Right, the 2009 study, that one estimated 29,000 future cancers from the scans done back in 2007.
So what happened? Did the danger really jump that much, or did our understanding of it just get a lot better?
It's a combination of both, actually. The researchers point to 3 key factors that explain this huge jump.
Okay.
The first one is the simplest. We're just doing more scans. CT utilization is up 30% since 2007. We went from about 69 million exams to 93 million.
Okay, a 30% increase explains some of it, but it doesn't get you from 29,000 to 103,000.
No, it doesn't. That leads to the second major factor, something called multi-phase scanning.
Which the old studies didn't account for.
They couldn't. The data just wasn't available. But now we know it happens in about 28.5% of all CT exams.
Can you explain what multi-phase scanning is? Why is it such a high-dose technique?
Absolutely. So a normal CT is 1 scan, 1 dose of radiation.
Simple enough.
Multi-phase means they scan the patient multiple times, maybe 3, 4 times, in very rapid succession. It's usually to watch how contrast dye moves through organs or blood vessels.
So it's essential for diagnosing things like internal bleeding or certain tumors.
Vitally important, yes. But you're essentially multiplying the radiation dose to that specific body part by 3 or 4. It's an incredibly high-dose procedure. And the third factor, which might be the most important, is dose accuracy, or what we call dosimetry.
Okay.
The old 2009 study had to rely on sort of generalized national data or standard protocols to estimate the organ doses.
So they were using theoretical numbers.
Precisely. This new study used much better methods. They looked at granular, real-world clinical data from over 120,000 actual exams.
And what did they find?
They found that the actual doses patients were receiving in day-to-day practice were substantially higher than what the theoretical models predicted.
So it's like, we thought we were ordering a single shot of espresso, but the new data showed that in reality, we were getting a triple shot every single time.
That is a perfect analogy. The real-world baseline dose was much higher. So you take that higher baseline, you add in the frequency of high-dose techniques like multi-phase scanning, and suddenly that 29,000 projection.
It balloons to 103,000.
Exactly. It's a much more accurate look at the real-world consequences.
We should probably touch on the methodology, though. I know some people are skeptical about these kinds of models.
Of course. I mean, the study is based on the widely accepted BER7 models, which come from the national academies. It's the gold standard.
But they're still based on data from, what, Japanese atomic bomb survivors?
They are. And transferring risk from a massive, acute dose like an A-bomb to the low chronic dose of a CT scan is always a point of debate.
So how do they account for that uncertainty?
That's why the sensitivity analyses are so important. They ran the models with different assumptions, adjusting doses up and down, changing the volume, and even then, the projections still landed somewhere between 80,000 and 127,000 future cancers.
So no matter how you slice it, the scale of the problem is just undeniable.
So scale is undeniable.
So if 103,000 projected cancers is the new reality, what does this mean for patients, for the healthcare system? We've got this clear tension. CTs are essential. They save lives. But now we know the long-term harms are massive. How do you balance that?
The core takeaway, I think, for the medical community is that we can't just see CT as a benign tool anymore. Its power means we have to be much more critical about how and when we use it.
Moving from CT as the default to CT as a more considered choice.
Or even a last resort when there's no non-ionizing alternative that can do the job.
So what are the actual strategies being proposed to do that, to mitigate these risks?
Well, they really break down into four key areas. The first is just reducing low-yield use.
Meaning scans that are unlikely to find anything.
Exactly. And this means using things like diagnostic algorithms, maybe even AI, right at the point of care to flag a potentially low-value order before it happens.
But that sounds hard. Changing physician habits is never easy.
It's not. It's a huge challenge. I mean, it's 3 a.m. in the ER, a doctor's tired, the CT is the fastest, most definitive test. That's the default. We have to make the safer alternative the easier choice.
Which brings you to the second strategy, I assume, offering alternatives.
Right. Prioritizing things like ultrasound and MRI, which don't use ionizing radiation at all. This has actually been really successful in pediatrics.
But the big challenge with MRI is always speed and cost, isn't it?
It is. MRI is slow, it's expensive, and it's not always available. So making it a real competitor to CT in an emergency setting requires a big investment. The third strategy goes right back to what we were just talking about, dose optimization.
Okay.
We just need to standardize techniques across imaging centers. We know there's huge variation in radiation dose for the same exam at different hospitals, and if we can avoid high-dose multiphase scanning when it's not absolutely necessary,
That's the low-hanging fruit.
it's the lowest hanging fruit. It can lower doses immediately without hurting diagnostic accuracy.
So better training, better protocols.
Yes. And finally, the fourth solution is shared decision-making.
Involving the patient.
Involving the patient. We need to educate clinicians about low-value testing, and when there are real alternatives, we need to bring the patient into that conversation. If they understand the risks, they might be more willing to choose a slower, safer option when it's appropriate. You know, this whole deep dive just shows how critical it is to constantly question our practices, even for a tool as indispensable as the CT scanner. We are talking about 103,000 future cancers from just 1 year's worth of scans. That's a massive long-term impact that demands we take a hard look at what we're doing.
So, given that this dramatic increase in risk is driven by a 30% jump in our use of CTs and by high-dose practices like multi-phase scanning that often go unchecked, what ethical or regulatory mechanism do you think should be prioritized? Should the focus be on limiting the sheer volume of scans we order, basically, restricting access to control the total dose to the population? Or should we be forcing the immediate adoption of lower dose technologies and standardized techniques for everyone? Which one gets us to that necessary balance between diagnosis and long-term risk? That's your thought to mull over for the week.